So we'll first turn it over to Dr. Adetona and John Bennett.
Okay, well, thank you. Thank you, Joe. Good morning. I'm Dr. John Bennett, President of and CEO of CDPHP. And first, I want to thank our hosts, the Adirondack Health Institute, the Alliance for Better Health, and Better Health for Northeast New York for hosting this. And I want to thank Joe for his great speech and also his kind words. You know, every time I listen to what Joe has to say, I'm reminded how much work we have to do with really population health, because that's really what population health is all about. And there are so many things that he covered in his talk that, you know, we're trying to work on at CDPHP. And every time I kind of hear what he's doing, I start frantically scribbling down things of, oh, I have to think about this or do that. So that was indeed a pleasure. So just to talk a little bit about what CDPHP has been doing. So CDPHP has been around for about 35 years. And I'm proud to say I was there at the beginning. We continue to be locally controlled by a board of directors whose majority are local practicing physicians. And Joe had a slide up there that said, he talked about it, talked about what some of the successful components of the successful ACOs are. That I think he had some quotes from Alex Azar, who's our Secretary of HHS. And one of the things that was on that slide was that the successful ACOs tend to be physician-driven and physician-owned. And as the CEO of the Physicians Health Plan, I think that I like to remind people of that. And I like to tell people that, in my view, the most important physician ACO in the region is the Capital District Physicians Health Plan. And we are fully accountable in terms of every dollar for the cost of care. So I think it's important to remember that as we go forward. So as a result of our history, our culture, and our governance, we've really been able to deliver what we think are market-leading solutions in the value-based payment world. And I want to talk a little bit about our enhanced primary care program, which I think a lot of you probably are aware of it. Dr. Adetona is one of our real success stories in it. And I want to just talk a little bit about it. We kind of started this program, and it is a value-based payment program. And I'm going to talk a little bit about how we use data in it, and then Dr. Adetona will, give you her end of it. But we started this program back, it's close to 15 years ago now, because I've been CEO for 10 years. And at the time, I was actively practicing cardiology in the Albany region, and I was the board chair of CDPHP. We started this program. Our original goal was, we said, we got to do something about primary care, because primary care doctors are unhappy. This was 15 years ago. They're unhappy, they're underpaid, and we don't have enough of them. So we got to do something about it. So that was the original thing. And of course, consistent with our corporate mission to provide high quality, affordable health care to the residents of this region, we thought that would certainly fit with that mission. So we started this program 15 years ago. We realized that payment reform had to go hand in hand with practice reform. So we invested considerable amounts of money up front, and we made it an all-payer model. We started with practices that we had a high penetration in, because there are a lot of primary care practices in this region where we're, clearly 50% of their commercial business. And so we tried to pick practices that we have a heavy penetration into, and we used it across all product lines as well. So you get some practices that have really heavy penetration of CDPHP patients. But we also made a decision that we were going to make a community investment, and we weren't going to restrict the tools that we gave these providers to be used to only CDPHP members. So in fact, the tools that we provided to these providers were really able to be used on all their patients. And in doing so, we invested in things like a connection to the RIO, the qualified entity, which in this region is HIXNY, and I'll talk a little bit about that. We also did significant practice transformation. You can't just pay physicians differently. They have to be willing to undergo a transformation process. And so, because it's really, we're going to talk about data today, but it's really, data is one of the tools. It's about data, people, and processes. And it really starts with the people and the culture. And if you talk to the people that have developed the really cutting-edge, leading, healthcare delivery systems, and you look at the Kaisers of the world, you look at some of the new things like MedChen, you look at some of the new things like Iora Health, they'll all tell you that it starts with the people and the culture. So we not only did a payment model, but we did cultural transformation, which we still do to this day. We're actively involved in transformation of medical practices. We provide grants through the SIM program, which is a federally funded New York State program, and we believe that that's very important. So our payment model, to talk about that a little specifically, but not get into too much of the details, is off a fee-for-service. We now have about 80% of our primary care network off a fee-for-service. They're on a value-based payment model, which is not an insurance capitated model, because they do not have downside risk, and we can talk about that, why that is, and where they're at. But it is a global payment model. It is risk adjusted, and the good news for the primary care doctors is that the fee-for-service component is roughly 50% high. I mean, the global payment component, is roughly 50% higher than a fee-for-service equivalency. So if you looked at our fees, which are competitive in the market, the global payments are roughly in aggregate roughly 50% higher than physicians who would make in a fee-for-service model. So we've put the money up front. We realized we had to do that to medical practices, and we thought that that was our role to make that investment. On top of that, we've had what we call a triple aim bonus, which is quality, service, and cost efficiency, which enables them to get up to another 20 to 30% on top of that. So we really enhance the economic well-being of primary care physicians. Now, the good news is that we have data which shows that we have definitely improved the physician's lifestyle, not only their economics, but people feel, by and large, that more satisfied in the practice of medicine, that they're able to spend more time with their patients, and we've got data to show it. The HEDIS and other quality score metrics of these groups continue to rise at a faster rate than non-EPC groups. Our patient satisfaction scores are higher in these groups. And lo and behold, we've even saved some money. How about that? Which is obviously the holy grail and the home run that we've actually even been able to save some money. That said, the savings on the EPC model and the savings from any gain sharing program tend to deteriorate over time as you pick off those low-hanging fruits. We're now moving on to what's called a total cost of care model, where we have several practices which have a PMPM spending target, if you will, and if they beat that target, again, we have not moved to downside risk yet. We're dealing with a lot of independent practices, and I will tell you that having ran a large independent practice, I think you have to be very careful about giving particularly independent physicians downside risk. You have to be very cautious about that. But we are on a path to moving them to this total cost of care model. We then took this to another level, and in 2016 formed what's called Acuitas Health, which is our population health services organization. We partnered with physicians in the then Capital Care Medical Group, which is now merged and become together with community care physicians, to create a company called Acuitas, which provides, again, the people, the processes, and the technology. It has a technology platform around population health. And this is a payer agnostic. So we now have about a total of around 160,000 lives. Is this still on? Yeah. Around 160,000 lives in Acuitas of all payers, about half of which are CDPHP members across all product lines. And what Acuitas does is provide the integration of claims data and clinical data so that practices can get timely, actionable data, right? We've been on a long journey to get not only timely, not only actionable data, but timely data, right? Doctors and all providers need data that's as close to live as you can be. So our data in Acuitas on claims it fits with our claims run. There's no lag. We pay claims very quickly. Those of you who deal with us know that. So our data that's merged with the clinical data in the EMRs is very, very timely, and that's provided through Acuitas. Data is important. We've been on roughly a 5 or 6 year journey at CDPHP to build a data warehouse. We obviously have a large claims data warehouse. We're integrating that with our clinical data warehouse. We're doing that through a number of one-to-one connections with practitioners, and we're doing that through our connection with our regional QE, our qualified entity, which is HCSNY, which is part of the SHINY. Joe made some comments about that. He's absolutely right that the RIOs have not reached their full potential, but I will tell you they're making great progress, and I'd be happy to talk about that later. We have much greater penetration. I'm particularly proud of what we've done in this region around the qualified entity. In addition, we've hired a lot of data scientists and biostatisticians in data. So that's a lot about what we've been doing. We've coupled that with our physician engagement team, which has enabled us to present this data to physician groups so that they can know where to go and what to do. So I'm going to turn it over to Dr. Adetona, and she's one of our great success stories, and she's going to tell you what her side of the story is. And I'm particularly proud of this because not only is she very, very passionate, and when I first met Dr. Adetona, it was like, I had never met her, but she's saying all these things that, just made me so happy because she's doing this, and she's doing it, as she'll tell you, as a solo practitioner. And she's doing it with a population that's largely Medicaid. And I think that's extraordinary. And the consistent quality, service, and cost efficiency metrics that she has achieved is truly outstanding. So she's an extraordinary practitioner. So with no further ado, I'll turn it over to her.
Thank you, John. Dr. Adetona?
Thank you very much. Thank you, Dr. Bennett. Thank you for the organizer of this conference this morning. I'm pretty excited and honored to be invited to share what I do with everybody today. And I like to be practical, to just bring to you how I get things done. So, my full name is Adetutu Adetona. I'm a solo family physician in Troy, New York, and I have a patients panel of over 2,500, of which 60% is purely Medicaid, 30% Medicare, and 10% others between commercial and BB paying patients. I'm going to share with you my journey from fee-for-service to value-based payment. In the 1920s, a professor from the Yale University by the name Charles Winslow stated that the goal of every generation is to redefine the unacceptable and act accordingly. Putting this into context of today's health, it will tell us that we need to prevent diseases and promote health.
We can't hear you.
Oh, sorry. It will tell us that we need to prevent diseases and promote health. Therefore, let this change begin with us. The wonderful Supreme Court Judge Ruth Ginsburg once said, I quote, "Real change, enduring change, begins one step at a time." I started the transformation from quantity to quality taking little steps, and when I got more comfortable, I would take bigger strides. Like most of you, I was engraved in fee for service. I learned it, I knew it, I was breathing it. But suddenly in late 2003, I went out to have my last child, and when she was 4 weeks old, I was out of job. I was called by the hospital that employed me. I was working in a clinic and said I'd become unaffordable. At this stage, I was seeing between 33 and 36 patients per day. It was a revolving door. The numbers were great. And I just could not understand why all of a sudden I became unaffordable. Rather than panic, I took the bold step because I knew I had the patient's population. And my patients knew me. We developed a trusting relationship. I told the hospital that please don't close the practice, I'll take the practice over. Never done business before in my life. But I didn't think it was something that was going to be difficult. So I just asked them for the reason. They said they weren't making money. So I said, please turn over the financial papers of the business to me. Yes, I looked at the papers. They weren't collecting anything. So what did I do? At that stage, I just reduced the operating cost. I reduced the staff, I reduced the rent, and I made sure that every patient that I saw, they had current health insurance, it was valid, and it was my name was the provider on the card. I continued the fee for service. I turned things around. Then came the change, the birth for value-based care, moving from quantity to quality. I must say many thanks to CDPHP. Through the support, through the education they gave, I found this very useful. It really gave me feedback of my performance. I'm one of those providers that I always believe at any stage that I give my best, I put my best in, that I'm always performing well without having a benchmark to really see what my report card was. Very often, I'll receive report cards and I've done woeful. Rather than sit back and continue the bad practice, I seized every opportunity to improve my care. My focus now shifted when value-based payment started. I became very proactive. I stopped being reactive. With a game plan of keeping my patient healthy, keeping them out of the hospital, I started promoting healthy practices. How did I do this? We're talking about data. I use data. I breed data. And I classify data into two: data for my patient and data for myself. What is this data for myself? The data for myself is that information given to me or collected that allows me to be the best physician I can be, to improve what I do on a daily basis. I look at my report card. You can say every physician, we tend to be competitive, and I like doing well. So when I look at the data, I seized every opportunity. I work on things that I'm not doing well. If it means studying more, if it means watching YouTube, YouTube is my favorite. Everything you want to learn, somebody has done it. So I look on the YouTube.
Don't give your secrets away.
This is so that everybody else can do what I'm doing. It's really not a big secret. So the second data is data for my patient. And I collect this data in different ways. We cannot succeed without embracing innovation. It's just too much information to deliver quality care when you see a patient. And I often go fully, well, as much as possible, fully armed every time I walk into a room to see that patient. So the data for the patient, before I even go to the data for the patient, John has said earlier on that a patient-doctor relationship, I tell you, this is the key. You have to have a good relationship with your patient. They have to trust you. They have to believe in you. Because if you go to the store and you have a good experience, good customer service, you are more likely to go back there, not to talk of human services. When somebody comes to see you about their life, about their health, you have to let them trust you. Now we're talking about social determinant of health. Social determinant of health is really what is happening to that patient outside the doctor's office. What is impacting their life? What is making them feel bad? What is making them feel seek for help? So it is in developing this patient-doctor relationship that you really get to the core of how you're going to help your patient. They don't have food, they don't have transportation, then you can help them. Then what you give them is, whatever medication or whatever therapy you're going to give them is obviously going to help them.
Dr. Adetona, can I ask you to talk a little bit about how the relationship with CDPHP helped you do this kind of transformation? So I think this is really, a core of what the panel is about. And, all the great things you're talking about, it sounded from John's introduction that these relationships is what facilitated some of this desire that you had, but you needed a partner, and it sounded like CDPHP was the partner.
Sure. I'm sorry. I get passionate and I just go off telling stories. Okay. So with CDPHP, the data that I get from them is, I call it the drill down data. I can go to the nitty-gritty of each and every patient, starting from the gap list, when they were not when they were last in the hospital, the physical, the immunization, the medication I have them on. Coupled with that, I also use health exchange information, which is ICSNI in this area. ICSNI will allow you to know exactly who your patients are seeing, where they've been to, and in so doing, when you go to see your patient, or even if you haven't seen the patient, you know they've gone to the emergency room, you know they've gone to urgent care, you know they've seen a cardiologist. All that information is right there for you to deliver the care for your patient. There's a scorecard that tells you about your pharmacy use. It tells you about your referral rate. It tells you about your lab. So all this I look at as well to save costs, because we're talking about saving the health system. So as you're delivering quality, you're also reducing the cost. So with the information or with the data from CDPHP, the pharmacy cost is there. And I just give you an example again. The only way I can explain what I do is just to be practical. I have no other way of saying it, so you have to bear with me. Just this week, just yesterday, I saw a patient, my last patient for the day. I told him to come back. Multiple medical problems, weighs about 400 pounds. He had been in the hospital 2 weeks ago. He came to see me, but when he came, he did not come with any of his medications. I told him, please go home, go get your medications and come back and see me. The reason I did that, this guy was on 35 medication. So what did I do? I reached out to CDPHP. I reached out to the pharmacy department. I said, please look at the medication list of this guy. He's coming back to see me. He came back to see me, brought all his medication. We sat down with the help.
In a shopping cart?
Pardon?
In a shopping cart?
Yes, literally, plus his oxygen. So he came, yes.
Gracious.
So he came in with 2 tanks of oxygen because his oxygen will run out, and he came in with a big bag that he was carrying along. Before he came, CDPHP pharmacy, they sent me ideas of what to combine, perhaps what to take off. By the time he left, he was now on 16 medication. And the reason that this guy was readmitted between the 2 weeks that he saw me and yesterday when he saw me was he went into acute renal failure. He had been on furosemide 80 milligrams, Bumex 4 milligrams. So that complicated things. So with the data information that I have, I was able to change things for him.
This is a great example. Absolutely
Yeah,
terrific.
and she told me this example as we were sitting in the audience waiting for you to speak. And she also, we talked about the fact that our pharmacy case manager was alerted to this and worked with her on this. And that's the kind of relationships
Right.
that we've developed.
See, and these are the kind of things that I think, you know, as a group, when we talked a little bit earlier about the predictive part. If you start looking at a panel of patients, anybody who's on more than 10 medications needs active medication management, right? Anybody who is on oxygen, who has other comorbids, you know, this is the proactive part of engaging patients outside of the practice, where partnerships with the plans and the practitioners and community-based organizations, because very likely this person is getting services from community-based organizations also, right? It may be food service, it may be transportation. All of these things are these multiple variables that when you start to absorb all of this, you really understand it's that tip of the iceberg that everybody can see, but it's that rising risk also that you really want to interact with, because those are the patients that are your next group of high utilization, high cost, high comorbids, and that's where to really intervene. So this is a terrific example. The last time I saw Dr. Adetona was at the NICE-Tech presentation, and she was receiving an award that's very well deserved.
Thank you very much. Thank you.
So I'd like to turn it over to Dr. Leung from the Koinonia Primary Care Practice. Dr. Leung?
Okay.
That was terrific.
Thank you.
Hi, good morning. Can you hear me? Great. Well, actually, I want to tell you a couple more things before we dive into it. I think that will help you understand both my excitement and my intimidation about data. I'm a licensed psychologist. That's what they printed on the sheet of paper. Great. I'm one of the few New York State licensed psychologists who somehow is trying to swim in this world of population health, because as you know, clinical psychologist is pretty comfortable to be in one place. That's my office, seeing one person at a time. And so fee-for-service is made perfect for me, except that I should have got my degree 20 years later, so now I'm in a collision course with VBP. But I think being in that grueling psychology PhD program that most of my colleagues can share nightmares about really give me a sense of two things I think really prepared me well for the value-based payment world. One is appreciation of data, because after all, you have to tame that beast in order to get your dissertation done. And my dissertation happened to be a little bit larger, so I have like 500, data in trying to explain a model. Number two, I think, is the appreciation of knowledge, that, there's that sense of you keep on learning until you really say that, I'm not interested in learning anymore, which won't happen to people like you and me, right? So just really want to encourage you. A lot of it is, if you cannot overcome it, if you cannot really run away from it, really try to learn it and tame that. My other title, actually, oh, by the way, finally meet you today, Dr. Bennett, because I do visit CDPHP every 2 months or so, because I'm on board of the utilization management.
You're on our committee, yeah.
And the QS AG committee for the quality stakeholder. And it's just a vast of learning experience, but also I just really want to applaud you and your lieutenants, so to speak. A lot of great people in there doing this stuff. My title, actually, in our small integrated medical practice called Koinonia Primary Care, is Director of Behavioral Health. We are NCQA Level 3 PCMH 2014 standard. 2001, compelled by faith and driven by compassion, the clinic was founded by Dr. Bob Paglow. And that's basically is a response to the health disparity among the uninsured and underinsured residents of West Hill. According to the data that we look at recently from the police department, is really the most crime-stricken, and we know that it's one of the poorest as well as most underserved neighborhood in Albany. 29% of these patients.
They're asking if you could move the mic a little closer to your face.
Okay, all right.
Better?
Better? Okay, maybe I talk louder too. Okay.
Would the echo go away if you turned off the other microphone?
Turn off the other microphone.
So only one's on at a time? I just wonder if it stopped yet.
Where's the switch?
I don't know, but it's a switch on that. It works with webcams.
Even closer, okay. So 29% of our population are a combination of commercial insurance and unspecified, meaning they have no money to pay. 71% of our population is Medicaid and Medicare. In our clinic, we see probably close to $10,000 patient visit a year, just over 2,000 individual patients. So far, we have been fully incorporated now, behavioral health services into the primary care setting, actually since 2012. That is after 10 years of trying co-location, and it doesn't really take us anywhere. Perhaps I think we are perhaps one of the first clinic in our small practice in the capital region who do full integration of behavioral health and primary care long before any financial incentives or funding is available. Personally, I have not really heard of VBP until just probably a little over a year ago. Maybe I didn't pay attention to it, but really that is a very new thing for me to learn now. So I'm going to tell you, try to stay away from too much of the downer first. I'm going to tell you some of the exciting things we are doing in our clinic, and then I would still go back to some of the juggles or just some of the struggle we are still facing. So we are juggling many balls in our office. In terms of the data and the data sharing, we have learned to adjust our workflow and adapt to data and technology. So the few things that is close to my heart with my behavioral health team is we focus on the case finding and screening and referral to care. That is to facilitate referral and tracking our cases through now is the newest version of ECW and the data sharing mechanism. So we have to juggle all those in order to be accountable in this process. We also look at the decision support for measurement-based stepped care, which means that we look at the evidence-based guideline, maybe depression, maybe anxiety, that we form a treatment protocols that work for us, so we can systematically track the symptom severity, and then can adjust the intensity of treatment when, especially when we look at the data. In the afternoon when I present, in my breakout session, you will see those graphics. Actually, we are very fortunate that we have a retired engineer who volunteer at our place 4 days a week. And he basically take a look at the clinical and be able to build a very simple kind of graphic depiction. And we can just open it up also within the eClinical. And that kind of graphic presentation help us to see, as well as we can just turn the screen to our patients, say, see, this is where you drop off. This is where your symptoms start to peak again. Now, obviously, it's more a case-to-case kind of scenario. And it's not relevant to have to show them, this is how the population doing and how bad you are doing. We just really want them to see and also take control of their own healthcare and behavioral healthcare. The other things that we focus on, again, about data sharing or data prospect is information tracking and exchange among providers, as well as our funding agency or incentivized, yeah, you can call it funding agency. The tracking tool that we use is Case Management Tracking System, CMTS. It's made or it's put together by University of Washington Ames Center. It is a competent tool, sometimes cumbersome, but it did its job to help us to track and manage follow patients, including the severity measurement, attendance at visits, and the care management interventions, plus selected medical measures like blood pressure, A1C, when we need to look at it. The unfortunate thing is it's not integrated into the EHR unless we are willing to pay our e-clinical, kind of like, to me, it's a ransom money that I don't have. But, so the other part of the tracking tool also enable us, or, you know, right now we are looking at how we can also do more tracking with some CBO, the community-based organization, just came on board. I see Sarah Adams there, and we just start to partnership with them. Even closer, actually, we have been in partnership for a while, but now they have an embedded CBO community worker, Trinity Alliance community worker at our office 5 days a week. No, don't worry, we're still using Bennett Cares, we're still using CDPHP in-source case management, but we're just kind of like attacking this social determinant of health, you know, kind of like heads-on. And so these tools first intimidated us, but after a while it's like, well, you know, may as well, you know, make good use of it, and we find that as we are willing to, as I am willing to step in the role, say, okay, I'm going to do it, and it make it easier for me to talk to my staff and the doctors to just buy in. And I think I agree with you, Joe, partly, that it is science, but I think our heart and also I think the behavioral science part of it is really our art. And if we don't really get a point of whether it's buying in or cultivating the sense that, you know, we can do it and we can do it one step at a time, we would never have got to where we are.
Great, terrific, thank you so much. Allison?
Hi, everybody. Is this one on? Yeah. You guys can hear me? You know? Is that better? Okay.
Good.
I will stay super close to this. Good morning. So I actually have a different perspective to provide, I think, today. I am not going to talk about my own individual experience, but really talk about the collective perspective of what's often referred to as the CBO sector in this equation, and talk about some of their collective experiences and how we've looked at this issue and some of the challenges, but also some of the exciting parts of the real integration of the provision of human services into the healthcare system. So I represent about 170 nonprofit human services providers, and I do actually want to just point out that I don't want to say take issue, but I find it strange that we refer to this sector collectively as CBOs, because I also think that healthcare is a community-based service, and so it's an odd distinction to me that in this sort of that's how we talk about community-based organizations, so we throw them all into that bucket. Our language in this field is really the human services provision, which is, I think, a different distinction. I think we all collectively do, again, serve the communities. So I started looking into this issue as the state did disrupt, and more conversations were going on about value-based payments and what that meant for nonprofit human services providers. And I actually brought together a commission of people from my sector, as well as some from the healthcare sector, that have been looking at this. And we put out a report in April that really talks about the challenges and, again, the opportunities of adjoining these two sectors. It's called Integration of Health and Human Services, a blueprint for partnership and action. And so if you want more background on this, I encourage you to take a look at that on our website. But I think the main thing I wanted to make sure that I shared with all of you is really the financial realities of the nonprofit human services sector and where most of their funding comes from and what that means for their ability to come to the table. And so that would be helpful in thinking about how to partner with this sector, because it is a very different sector than the typical healthcare sector. The financial realities are very different, and the motivation for their work is somewhat different too. They are looking at wellness overall, and I think I love this conversation going on about social determinants of health, because I think what's happening is there's an expansion of what's health, and there's a sort of blending of wellness into that conversation. And I do think that a lot of like the measures of well-being need to be measures of well-being, not necessarily measures that are very clinical. And I do hear a lot of that going on, and so I'm excited that New York is going in this direction. But I do want to point out that most of the human services organizations, well, first of all, there's a lot of human service organizations. So things like IPAs are really important to be able to exist, to be able to connect to those. And so there's got to be some more efforts and some more investments in the creation of those, because to expect the healthcare sector to be able to go one-offs is and it's happening, is hard and challenging, and I think we need to make it easier by creating collectives. I think that would be very helpful, and there are a lot of good examples of that, but I do think we need to be more proactive, and potentially the state needs to be even more involved in helping those get created. And I think it would help also the nonprofits be able to come to the table and really do the risk assessment and that they need to do to decide whether or not it's fiscally responsible for them to enter into some of these relationships, which is something that's a challenge for a lot of them, because frankly, they don't really have a lot of margins for error. The reality is most of their money comes from government contracts that are routinely underfunded and pay late. That is their fiscal reality. That's it. We are working really hard at the Human Services Council to try to change that, and really trying to fix that reality, but that's where they are. So 20% of nonprofits, human service nonprofits in the state are insolvent, actually, where their liabilities outweigh their assets. And another 60% have maybe 3 months of run time. So that's where they're starting from. Now, when I say that, because it's important to understand their ability to take on risk and even to come to do that assessment of the risk and to spend extra time and energy of their staff to think about these relationships and how they can add value to the conversation. But I will say on the positive side, they are nonetheless doing it. There is a lot of examples of people interested in these conversations, but what I'm seeing a lot of is the ability, and data is critical to that, so their ability to be able to prove and demonstrate that they can help the financial bottom line now that the incentives have shifted on the healthcare side. So data is critical to that, and they do struggle with data because, again, they're dealing with what I call cost minus contracts. So the contracts that they enter into with government tend to need additional funding, which is why they have to raise dollars through private sources to actually even do the services that they're doing through government. So their ability to make those investments and get the data and do the analysis that's important is hard. So I do think at some point there's going to have to be a real conversation with where the capital dollars are going to come. And I know they're happening piecemeal again, but it's piecemeal. It's not systemic. And so there needs to be, I think, a conversation about that. How do we get those capital dollars to those nonprofits to think about the data? For example, in our report, we have one example where we looked at a nonprofit that had 26 different data systems that they had to comply with as a result of their government contracts, right? So that's just their government contracts. And that's, yes, I say something, yes. And the dollars aren't really there to support that. So then to do the analysis and I think what's important to think about too is that they're built to respond to RFPs that government put forward. So when they're responding to an RFP, they're basically looking at a scope of service and then they're deciding and doing an analysis that's whether or not they can afford to do that service at a loss in some respects, right? So that's how and so then they do that analysis and they either apply and get the contract or not. And that's what they're built to do. In this healthcare side, what we're really asking them to do is to come to the table and say, how do they set their prices, which they don't currently set their prices. The government sets the prices, and again, they figure out whether or not they can afford to do it. How do they set their price, and then talk about the value that they would add to the system, which is a totally different business approach. It doesn't mean that they can't do it. A lot of them, again, are doing it, but it is. I really appreciate that it starts at the actual physician working with a CBO that they have in the community to figure that out together. It's got to be a real partnership, and then making that case together to the actual payers about why this is of value and makes financial sense, and that they should be making the upfront investment in the nonprofit, which is going to be critical for them to truly come to the table and have the data system that is necessary for us to understand what the value is. The other thing I would just say is that it seems like a lot of these relationships are oftentimes where the nonprofit is giving the information to the healthcare side and not necessarily getting any information back, and that's not going to help the long-term integration, because the nonprofits, especially if we want to move them and evolve them to a point where they truly can do value-based payment arrangements that do include risk, they need to be able to, and that means that they're being held accountable to their outcomes. Well, they can't hold themselves accountable to outcomes if they don't have any data and they can't do their own analysis. And so that has got to be an important part of what we're thinking about here, is how are we getting the data to go both ways so that we're problem solving around communities that talk about population health together, right? So we're really taking all the expertise of the different individuals. So I think that bottom line, what I would say in all of this is that we need to recognize and appreciate the realities of where the human services sector that we're trying to connect with are. Think about the capital investments and that are needed to get them to the table. And I don't have the answer for where that money comes from, but I know that it's needed. And to say that we need to be incremental in our change, incremental in our measures, meaning that I know we're trying to drive towards measuring for outcomes, and that's important. But the nonprofit needs predictability in its payment given its risk limitations, and so that means that they need to know what the price is going to be and when they're going to get it. So you may have to pay at the time of intervention, not when you actually see the outcome, with an understanding that there's going to be some period of time that you will measure the outcome and the data will get better and we will evolve in this direction. And so realizing that we can grow the sector towards value-based payment, I think, is where we need to start from, and not jump there overnight, because it will not work. And the nonprofits right now are struggling with trying to come to the table, but there are real legitimate reasons from the way they get paid and most of their money comes in that undermine their ability to come to the table in a meaningful way.
Thank you, Allison. So we're going to open it up to questions now. There are some microphones that will be exchanged in the audience. Let's go in the back right there first.
I better stand up.
He's going to go first.
This is a question to Allison. My name is George Clifford. I'm with the Albany Damien Center. Allison, as CDPHP and others have invested in cultural transformation with a transformation of primary care to more patient-centered focus. We see some successes coming out of that. But the other thing, I think, from healthcare that we're seeing, and this is where it comes into the Human Services Council, is that over the last 5 years or so, there's been an increasing number of healthcare organizations who have gone through mergers, acquisitions, or affiliations. And so the question to the Health Services Council is, in order to address the underfunding, perhaps the need for improved economies of scale, should the direction be a merger or affiliation of some of the smaller community-based organizations, because size does matter when you're negotiating value-based payment?
So I understand that perspective, and I'm not against mergers in any way. I'm kind of neutral on it. I think it depends on the organizations, but I have a couple of things to say. One, mergers take time and money, so that's real. I also would say there is an increase, number of affiliations happening. I've seen an uptick in those, and I do actually think that the reality is, if you look at the numbers, size doesn't matter as much as we guess that it does. We have seen in New York City, FEGS went down. It was one of the largest human services providers. $250 million, probably one of the largest, went down. And in fact, it was too big because because what happens is if you think about what I said, if you have a bunch of government contracts that are all coming at a cost minus situation, the larger you are, the bigger that gap is. And there's only so much private funding out there to fill that gap.
So you can't make it up in volume.
You can't make it up in volume. In fact, you have a bigger problem on your hands. I actually think that but I also appreciate that super small organizations, there's no way that they can come to the table reasonably. That's why I said the part about the IPA being important. I think we need to affiliate those organizations. That doesn't mean they need to merge, but affiliate, and not necessarily financially, but through an IPA kind of situation. I think that's the better way of connecting them to the healthcare side.
John?
Yeah, so reacting a little bit to the question and also to your comments in general. I was sitting here listening to you. We've never met before. I wanted to break out in applause. So in a delayed fashion. So I'll never forget my journey that started when I, for the first time, went down into Sheridan Hollow and realized, and I said to some of our folks in state programs, because we have close to 100,000 Medicaid managed care lives in the four-county, in actually more than the four-county area, but in our footprint. And I said, how many people do we have who are homeless, all right? And who's giving them services? And they told me all these organizations, and I said, well, what kind of relationships do we have with those organizations? And so we have full risk for those lives. And so now we've started building those relationships. Then I saw the DSRIP program come about, and with all due respect, I was very bothered by the fact that we have $8 billion spent on a population, and the money was funneled through, obviously PPSs, which included these organizations, but I will tell you that most of the PPSs throughout the state are kind of hospital-centric organizations. And I said, where are these human services organizations? Now I'm going to call them that forever, so thank you. Are they going to get enough of the money? So as a side question, I think we ought to look at that in terms of whether they're getting enough of the money, because I can tell you at CDPHP, we know that when we infuse money directly into these human services organizations, we get results. We get the same kind of results as we get when we give it to the primary care physicians. And then the only other final thing I'll say is, if you look at other countries, the United States spends so much money on health care, which is that 10 to 20% of all that stuff I did when I was a cardiologist. But really, most health outcomes are related to everything else. And the human services organizations are really can have an impact on all those other things. And that's a profound mismatch. And if you look at other countries, they spend a lot more on human services. So it's not about nationalizing healthcare or doing all that kind of stuff. That's not really what we need to do. We need to invest more in human services. And we have a Secretary of Health and Human Services, right? And we have a department nationally of Health and Human Services. And I'm not sure they ever really talk about the human services side.
They don't.
So I'll tell you something else. I'll make a promise to you. When I meet with Alex Azar next month, I'm going to ask him, what about human services? So thank you.
Thank you.
My name's Bob Peglow, and I have a question for Dr. Bennett. I wanted you to address the issue of small practice, large practice, in terms of, especially intervening in stressed communities. We're a small practice. I think, we've been innovative, we've been creative, we've been sacrificial in terms of the care we provide. And we're fortunate that we have a 4-day-a-week, 4 full days a week volunteer to help us tame the data demons. But if we didn't have him, we'd be lost. And for sustainability purposes, you know, we can't count on 4-day-a-week retired volunteers to be with us forever. And I think small practices are particularly equipped to deal with these distressed neighborhoods. It becomes an issue of trust and so forth for our patients, and we know them. You know, in our practice, everyone knows your name. And that's important. So I'm just wondering, in terms of going forward, in terms of support, what you see as CDPHP's role perhaps in supporting us and helping us tame the beast of the data demons.
Oh, wow. Oh, what a great question, because that's something I think about every day. That's one of the reasons why I was so pleased when practices like Dr. Adetona's rise to the top. And, you know, we view that as our mission. So, you know, I had a long journey in medicine. It started out in a 3-person cardiology group. It ended up, you know, as the CEO of a multi-specialty group with like 100 doctors. My thinking on how physicians ought to practice has changed dramatically. I see the value of smaller practices. Even if you're in a large corporate environment, I think you need to be in a small unit. So let me tell you what we're doing. We are beginning to aggregate smaller practices from a financial standpoint into virtual units, so that we can look at the number of covered lives that these practices have together and create an actuarial spending target for them, and then be able to share savings with them. So that's one thing. The other thing, of course, is our traditional EPC model, and we can talk offline about that, and I'd love to do that with you. I'm aware of the work you're doing, and it really is God's work, and we need to take, like, we need to expand this model of what we've been able to do, because there are other practices like Dr. Adetona. Fortunately, she's not an N of one. There are others, and this cottage industry of medicine, which we see that everyone thinks inexorably is going to go away, I pray that that does not happen, because doctors at the end of the day have to relate to patients one-on-one, and it's very hard to do that in bigger organizations. I lived through it. My practice was a lot different when I was one of 3 cardiologists, and then when it was one of 25. And I'll tell you, I got very frustrated at the end, because I'm on call and I don't know who I'm talking to, okay? And that's scary. So we're doing things like trying to aggregate these practices from an actuarial standpoint. We need to get, we're pretty aggressive in terms of support of smaller practices, and that's a discussion we can have offline.
I think another thing that's important too with this is trying to understand what matters to you in a practice setting, what's important. Because there are, I think, applications and tools, and John and I have been talking about this, where somebody can be able to go in on a portal and look at templated data sets of things that are important to them. You don't need to see everything, but being under, if you define what's important, what you see as actionable, those are things that can be simplified and automated and really pushed out to you and give you what you need at the level that you can use it at. And I think this is really important to work with an organization like John's that has the capacity to do this kind of work, because you don't have to be overwhelmed with something that can, pull off a moonshot, right? What you want to be able to do is look at what you need, act on it, and then go back and see if it worked. It's really as simple as that.
Joe?
Yes.
May I say something?
Please.
I worked for that man for the last 17 years. I can finish the second half of his sentence usually. But it's been an honor to serve with him, so I'm not offering an answer to my boss, because he could have asked me on the way back. But I'm actually kind of like piggyback right on that. As I told you, Joe, we will stay away from a lot of the downer talk, but really it's the day-to-day kind of struggle for us to, like the ransom money I just mentioned. There's a real opportunity for this small practice, and some maybe in the area can upgrade the tracking system for behavioral health. That's a very important thing to do in order to be accountable and to be able to stay on track with the funding source. And so the opportunity is for us to upgrade it to a tracking system to be in a pilot study. So that's free, right? But in order to make it work, ECW have to be willing to make it automatic so the two systems will be talking to each other. The price tag right now is $12,000 just for this year. So I have been asking, praying, begging, pounding on the door, including Ann Fernandez a few days ago at CDPHP. Where could we get this $12,000 ransom money in order to upgrade it? So Ann actually said, well, talk to the Alliance. I suppose there are people in here from the Alliance.
Okay, other questions? Dr. Mangianet. Here comes the mic.
Thank you. I have a question for you, Joe, as well as Dr. Bennett. As state is pushing and moving forward their VBP arrangements, what's their vision for data in terms of data analytics, sharing data with partners? Are they going to expect the plans to provide the data for VBP? Is state looking to providing for Medicaid patients?
All right, so I'll defer to John from the plan perspective, and then I'll give you the perspective from what I see at the state level.
Oh, okay, you want me to go first? Okay. Sorry. So from the plan level, so from the CDPHP standpoint, if we have a value-based contract with a provider, we want to provide you all the data. There's no conflict there. Just, we just need to make sure, A, it's in a secure format. We have HIPAA concerns, the whole data security issue, not only around HIPAA, but around theft of data, et cetera. We need to work out the mechanics of it, but, we need to give you all the data. We have no, I will tell you at CDPHP, transparency is one of the many things that I lecture about constantly. The days of health plans withholding claims data, and to me, are over. And when I see health plans that won't do that, I say, don't deal with that health plan. Our mantra at CDPHP starts with, someone wants data from us, our first answer is yes. Now, that's a very important distinction, because our first answer used to be no. It didn't always be that way. Our first answer now is yes. And then it's like, well, if there's a problem, like, what is it? Is it around security? Is there something that's illegal? Is there some contractual imposition that we have? You all saw the Wall Street Journal article maybe yesterday that said that some hospital contracts say that you can't say what their prices are. We got to get rid of that, okay? I think we need statutory relief from that, so that can't happen. We need transparency around data.
What he said. Truthfully, I do think, and we work very closely with the RIOs, several of them. I think the RIOs have been funded to the tune of about, probably John may even know better than me, something like $3 billion over the past 10 years or so. This is an enormous amount of money, and several of them, like HCSCNY and Healthix, I think are models. Others are getting much better. But once the state empowers and also kind of twists the arm of these organizations and decides who is going to be the RIOs of the future, which I think is really what needs to happen. I don't think we need 10 RIOs. We probably could do with very much less than that, and let the cream of the crop rise and let data be exchanged freely. I mentioned this to Eric and Lou earlier. When we do focus groups with patients and ask them a lot of different things, we have them speak to nurses and social workers and doctors and talk about asthma and diabetes and all kinds of things. And we ask them about exchanging information. They are stunned when we tell them that their cardiologist, their endocrinologist, their primary care doctor doesn't know what happened when they went to the doctor the week before, that they don't know about medication fills and adherence, and the comment that you made about a patient on 35 medications. Patients don't expect that, right? Not at this time. at this maturation of a care system. So I think the RIOs really are the key to the future. The letter that I shared with my PPS colleagues that talks about universal data exchange about behavioral health, substance abuse disorder, if this is socialized throughout all of the state, then data could be exchanged with everybody at all times. And it's also on providers, I think, also to encourage patients and educate patients and make them aware of the importance of data exchange. And I also think it's on the state when patients, renew Medicaid to have a opt-out from data exchange, right? They could certainly make part of their renewal that data will be exchanged freely with all your care providers unless you say otherwise. So there are a lot of things that could be done, and I think those are things that could be very painless and really would be very fruitful in terms of care coordination and supporting all the work that organizations are trying to achieve. Allison?
Yeah, I just wanted to, the number one recommendation in the report I mentioned before, because this also goes back to connecting to the human services side of things, was that there was a public good funded, so basically the government funds,
right.
just like they fund highways and they fund, this is, technology is how we communicate with each other and connect. And if we're trying to connect the human services and the healthcare side, then I think it's government's responsibility to think about what an investment would be and to on an ongoing basis kind of own the maintenance and creation of a system that connects and standardizes. Because my concern also is that there's all these pockets going on of connections and investments, and they're all over the place. Imagine when you did, if you could start from the beginning, which in terms of connection to the human services, we are kind of at the beginning, if we could standardize it, and the state has got to play a bigger role in that and actually fund it and own it so that everyone can connect to the same system and that the data we're collecting are standardized.
So there you go. So that does exist now. That's called the Shiny.
Right.
And the state, I've been on the board.
But it doesn't connect to the human services in the same way yet.
No, and that's one of our biggest gaps. So the Shiny does get public funding. We sold that public utility model to the state. We had 3-year funding for it. It's up after next year. We need to fight hard to get that money renewed. There also are some federal matching dollars that come with it. So the Shiny currently is funded to the tune of about $70 million statewide. And that is most of the money that supports the qualified entities, all these RIOs, and we will see fewer RIOs than we have now. And we need to continue that. Mm-hmm. And one of the biggest challenges we have is the human services organizations, connecting them.
Yeah.
So we're going to need more money to do that. Mm-hmm. I agree with you. I believe that's a public good.
And that's why they shouldn't walk away from it. They don't need to invest in it and walk away. They need to actually
continue.
maintain it. Exactly.
They need to maintain it. They actually need to invest more in it.
Well, and continuously, it's got to be a baseline thing
This is a public
just
utility.
like they don't walk away from roads or they'd crumble.
Right. That's great.
Okay, other questions?
Yes.
Hi.
Hello. My name is Brittany. From a payer perspective, I'm from MVP Healthcare. And Allison, my question is for you. From a VBP perspective, our level 2 contractors already need to work with community-based organizations, human health service organizations. I so appreciate your perspectives on these, and there's been limited perspective taking and challenges around that, especially from the payers to the community-based organizations. My question is, for the contracts and relationships that are already established, without a merger, without a coalition, what are directions that payers can take to support community-based organizations in their sustainability financially and data?
Yeah, so I think that's it's smart to, and I totally appreciate that. We've got to make this work financially for both sides, and that's the only way this is really going to work. So I just feel like let's not pretend like there's anything else. Like it's got to financially make sense because there are a lot of human service organizations that have gone to a lot of meetings around this stuff and sort of said like, you know what? I don't have the margins to go down this road, so I'm going to hold back for a little bit. And there's a lot of that going on. And I think that's a problem because I do think that ultimately for the communities it would be better. I would say that you have to think about a potential upfront investment. But in order for that to happen, you've got to be convinced that it's going to make financial sense for you down the road. You've also have to be willing to realize that you've probably got to take a bigger risk in the relationship. And whether or not that's feasible, I don't know. But that's, I think, the reality of the situation right now. And then I would say this is why I really want to try to get to a place where we can get a standardized language for contracts. I don't want nonprofits to make the same mistakes they've made with government, where they take cost minus contracts. I would like to help, sort of, this could be another market for the nonprofit sector, and then diversification of funding streams really helps to make robust entities that we need for communities. So I would say being, understanding what the real costs, and that includes like overhead rates, cost escalation clauses within contracts. These are things that basically don't exist in government contracts. And so thinking about what the real costs, and then the nonprofits have to be responsible to actually understanding their own costs and what their overhead costs are within that, and to basically say that how their costs are going to change over time and build those into the contracts.
Yeah, I think also what's important here is that organizations that are trying to engage these providers need to know what they want, right? They can't just be trying to fill a bill of saying, I'm going to be penalized if I don't have X number of contracts with these organizations, so let me just go out and see who's local. And there really needs to be accountability on both sides.
Agreed.
And an understanding of track record and history, efficacy, because you want to have a sustainable model. You want to have a model that's scalable. If you want to scale somebody up from what they do to triple the size of that, that's a big challenge for a lot of organizations, for any organization. So I think there are a lot of things that are going to go into making the organization successful, and we need to be very thoughtful about the way that works. But certainly project implementation dollars, a good definition of how they document what they have achieved on your behalf is something we spend a lot of time with the partners in the community that we're working on. And that really has led to them growing and becoming more viable. And there have been some mergers, right? Not a large number, but some really have looked around as part of our gatherings and said, it makes sense for us to get together here. There's opportunity to scale, there's opportunity to control cost, and people be able to branch out and do a better work together. So these are things also to be facilitated. I think we have time for one or two more questions. Yes?
Hi. Since we're talking so much about data, and I assume absorbing all of the data that's out there, working for community care as the senior program manager for value-based care, one of the challenges that the practices, and by extension the larger organization has, is the fact that we have so many insurers, we have so many reports coming at us, that we then at our level try to help the practices with, digest the data, as it were, give them what they need. So if they need to reach out to the patient, or if it's just a matter of getting records out of the chart that need to be forwarded on to, let's say, CDPHP, yes, we'll do that. But then there is work that has to be done at the practice level. And even in getting the practices themselves more engaged, like Dr. Adetona is in the data, requires so many, because we take pretty much everybody's insurance at community care. It's all presented in different formats. You have to have passwords for every one of the portals. It is just really, really different. It's overwhelming when you have practices that are actually truly trying to do the work that is going to make healthier patients and that is going to drive down costs. Does anybody have suggestions?
Yes. Yes.
John?
Well, first of all, on the state and national levels, the payers have been involved in those kinds of discussions with how we can standardize things. And the payers, in this community are willing to step up and, increase those discussions. Needless to say, that hasn't really happened yet. I will tell you that my quick answer to that is, you just described one of our main reasons for developing Acuitas. Acuitas is our solution, which also helps with that. It's a population health services platform, which is payer agnostic. And really, the medical practice is the customer, and they can then craft their own value-based payments with different insurers, use a common platform for all those insurers for data, and then translate that into common standardized practices. So Acuitas is that kind of interpreter, if you will. I mean, you know, we're not going to get to the point where every insurer is, certainly we can do better, but we're not going to get to the point rapidly where every insurer is going to have the exact same standards. Because insurers are competing, they need some competitive differentiation, and we compete very intensively with each other, and in this community you have 5 or 6 active payers. But one of our potential solutions to that is, that's one of the reasons why we developed Acuitas, to be that interpreter.
And I honestly, just to piggyback on John's comments, the complexity is probably not even fully there yet. So this is not, doesn't make anybody feel good. But, you know, having an organization like Acuitas or some other trusted partner that can facilitate that is really important, because a lot of this is enormously complex. Socializing all the data, all the electronic health record data, community input, the pharmacy data, all of these things is all incredibly important, and leaving out even one source really starts to minimize your ability to have the impact that you want. So it may be that, you know, a trusted partner in some capacity to do this work, because there are organizations that really have that skill set, right? They work with ECW and Epic and Meditech and a dozen others that are out there. They take in the data from SureScripts, and they take in Social Service Agency and claims data and Rio data and correctional health data and all of these other, you know, impacts of social determinant of health, whether it's coming from local, city, or state level. So I think it really is beyond the scope of most organizations, even big organizations, to do this. So finding a good partner that can do it for you is really probably the cheapest and most effective way, because then you'll get what you need. One more question, or one last question. Yes.
Hi, my question is for Dr. Bennett. I'm Lori Lavasser from Central Nursing. We're located in Troy. We're a home care agency. And I was just curious to kind of evaluate a little bit more on your value-based contracting that you have with the providers. Sure. Do you also offer that type of contracting with nursing in the community?
No, but would love to. As you probably are equally aware as I am, home care services in this community, there's a huge shortage of them. We struggle getting enough home care. So we would, you know, we're looking for those kind of partnerships as well, but I don't believe we have any, although take that as 90% certain, because I'm not totally aware of everything that goes on. I have to admit that, but I don't think we do. But we're interested in partnering in value-based payments with anyone that wants to talk to us. But we're also acutely aware of the shortage of home care services. I mean, you know, we need to, you know, more care is better in the home. You know, we've experimented with that and have a lot of programs with that. We do that in our Medicare Advantage population with a company called Landmark, which provides care in the home to the sickest of the sick of our Medicare population, which is also quite large. And so we're always looking for home care partners, absolutely.
So I want to thank the panelists, Dr. Adetona, Dr. Bennett, Dr. Leung, Allison, for participating.
This is it.